A very warm welcome to everybody who's joining us to this August iCMLf conversation. We are very privileged to have Professor Andreas Hochhaus from Jena in Germany here with us wherever you are in the world at whatever time, talking about the treatment of CML patients after failure of 2 TKIs, a very topical conversation, as you'll agree. So while, again, people join in, I'll just give a very brief introduction to Professor Hochhaus. So Professor Hochhaus is Director of the Department of Hematology and Medical Oncology, Coordinator of the University Tumor Center and Co-Director of the Comprehensive Cancer Center in Central Germany at Jena University Hospital. He is full Professor of Internal Medicine, Hematology and Oncology at the Friedrich Schiller University in Jena, and served as Vice Dean for Research at the Medical Faculty from 2010 to 2020. As co-chair of the German CML Alliance, Andreas has focused on enhancing access to clinical trials for all patients and especially driving patient participation. He has published 619 peer-reviewed papers and is co-editor of the in-chief of Leukemia.
Nicola, thank you very much for your kind introduction. It's a privilege to have the chance to talk to the global audience here. I think that's one of the limited advantages of Corona, that we have now the chance to do such global meetings very easily. And I see a lot of familiar names here in the list of participants. Welcome everybody. I see names from colleagues, from patient advocates, but also from members of the pharmaceutical industry. We are all one family. We are all interested in CML and want to advance CML management for our patients. And therefore, it's very good to have everybody together today and to talk about treatment of CML patients who failed at least 2 tyrosine kinase inhibitors. That's more important than we regularly think. That means not everybody tolerates the first inhibitor or has achieved a good remission. Therefore, we need alternatives, and we have these alternatives already. When you focus on the right column, these are the 2020 ELN recommendations. We have 4 drugs available for first-line treatment in most countries. We have ponatinib as another 5th drug for second and later lines of therapy. We have still allogeneic stem cell transplantation, and it's of course important to define which patients should go to allogeneic transplant in 2022. There is still a proportion. We transplant about 3% of all CML patients. That's a small number, but it's an important number because we need the decisions to transplant early enough. And in red, you see still side effects. We observe short-term and also long-term and also severe side effects to the tyrosine kinase inhibitors. And that's, I think, our most important message. We need to reduce, we need to eliminate the side effects to the long-term treatment, or we need to be able to discontinue therapy, and therefore we need a deep molecular remission with the chance to discontinue therapy. That's the overall picture of CML, and the unmet needs are depicted here. About 20% of patients switch to a second-line treatment in the first year. 40% of patients switch within the first 5 years. 50% of patients require dose modification due to adverse events. And most of the toxicities to the tyrosine kinase inhibitors are based on off-target inhibition to alternative kinases, which may produce these specific side effects like pleural effusions or cardiovascular events or others. Therefore, I think drugs which are more specific to BCR-ABL may have an advantage to target these side effects and may produce a faster response to the treatment. That's the hypothesis behind that. That's the hypothesis behind the development of new inhibitors. On the right side here, the 5 drugs are the licensed drugs: nilotinib, imatinib, dasatinib, ponatinib, and bosutinib. And you see here the specificity, selectivity of the kinase inhibitors. The red bubbles depict kinases in the kinome, which are inhibited by these drugs. And you see that dasatinib, ponatinib, and bosutinib are certainly multi-kinase inhibitors, whereas nilotinib and imatinib are more specific to ABL and BCR-ABL, but not only they still inhibit other kinases as well. We have now a new drug available, Asciminib, which is already licensed in the United States, will be licensed in other countries very soon. And Asciminib does inhibit only 2 kinases, ABL1 and ABL2. And therefore, the hypothesis is that this drug produces less side effects because the off-target inhibition is smaller. But of course, you could have the alternative hypothesis. We need the multi-kinase inhibitors for patients who have a molecular clonal evolution already, who need to inhibit the alternative kinases because BCR-ABL does not play a role anymore in the treatment of CML. This was the starting point when Asciminib was developed. When we choose an alternative TKI in all the patients, we need to define again or redefine the goals of therapy in this patient. If he was resistant to the first inhibitor, then of course the deep molecular remission and the treatment-free remission will not play a major role. The major role is to achieve a new PCR remission. That means major molecular remission in most cases. But we check the BCR-ABL mutation to select the biologically useful drug. We check the comorbidities to avoid additional morbidity by the tyrosine kinase inhibitor. And of course, we need to be sure that the drug is available in the given country. We know that not all the drugs are available in all countries worldwide. This is based on shared decision-making between the patient and the doctor based on biological and clinical parameters. The current tyrosine kinase inhibitors have all side effects, and we need to know these side effects to bring it together with the comorbidities to select the right drug for the treatment. When we talk about intolerance, we have the situation that some drugs show cross-intolerance. That means the same intolerance again, because it's based on a general phenomenon like liver toxicity. For instance, there are several kinase inhibitors which may produce the same liver toxicity as others, or cytopenias. Cytopenia is actually not a side effect in the strong sense of the word, because it's part of the disease. If the patient does not have sufficient normal hematopoiesis, you can give all the drugs, but any of the drug or all the drugs will produce a cytopenia again. That's a typical situation when allogeneic stem cell transplantation should be considered. But we have also specific intolerances to the specific drugs, like pleural effusions with dasatinib, and we need to define whether this intolerance is manageable in this patient. But the more drugs we have available, the less symptomatic treatment is needed, because an earlier switch to an alternative drug is possible. Therefore, in the situation we currently are, we have the choice between 5 or 6 drugs, depending on the country, and therefore we need to very closely observe the level of intolerance, and we need to be sure that the quality of life for the individual patient is good, and otherwise we want to change treatment here. And we have biological parameters which need to be considered here. We have for the first-line treatment the additional chromosomal aberrations which produce a specific risk. This is, of course, important for second and third-line treatment as well, because this is here parallel to BCR-ABL. This has nothing to do with BCR-ABL. These are alternative pathways which are activated, and the question is whether a specific BCR-ABL inhibitor is able to overcome these additional chromosomal aberrations. And we have the same on the molecular level, and we need a lot. We know a lot on the molecular level. We know which genes are important for the achievement of response, which genes are important for overall survival. That means we know the predictors, but not for the individual patient. We need to learn a lot, and therefore we created the iCMLf Genomic Alliance and joined the Harmony Plus project to be able to bring all data in this direction together worldwide and to learn which mutations outside of BCR-ABL are important for the selection of specific drugs or important for the direction towards allogeneic stem cell transplantation. It's too early to give you final results here. I just want to highlight this worldwide collaboration under the umbrella of the International CML Foundation. We transplant too late in general. You see it here from the European Blood and Marrow Transplant Society. We transplant more patients in advanced disease than in early chronic phase in green. And this is, of course, important because the outcome of transplantation in chronic phase is much better than in accelerated phase or blast crisis. Therefore, we need parameters to define which patients should go to transplant despite we have 6 drugs available. And for the tolerability of the treatment after resistance or after intolerance already, we need to define the optimal dose. We have, of course, labels, and the label for imatinib is 400, for dasatinib 100 to 140, for nilotinib in second line 400 BID, for bosutinib 500, and for ponatinib it used to be 45 milligrams per day. We know that this is too high for all of these drugs except imatinib. Imatinib could be, the dose could be increased if tolerable. For dasatinib, we know that lower doses produce efficacy as well and reduce side effects. We know from early trials that 5 times per week may be an option. This needs to be confirmed in the DASA-HIT trial. We know that 400 nilotinib BID is toxic, produces more cardiovascular side effect. Therefore, if possible, I would, even in third-line treatment, and of course, in particular after intolerance of the previous drug, I would start with 300 BID. And same for bosutinib, with 500 starting dose, we produce diarrhea, and therefore a lower dose, even if it's not in the label, is of course our advice. And for ponatinib, a systematic study was performed to demonstrate that the dose reduction to 15 milligrams over the course of the treatment is advantageous when we look at the side effects, at cardiovascular side effects in particular. But we need to start with the 45 milligrams in the resistant situation. Otherwise, the achievement of response is not optimal. Bosutinib 500 milligram per day was tested in the BYOND study in second, third, and fourth line of therapy, and actually the response levels were remarkable. Very good PCR response levels. That means it's worth to try an alternative drug also in third line therapy. If this is manageable, tolerable, then the achievement of deep molecular responses is possible even after resistance to the previous drugs. I come back to the ponatinib story. This was tested in the OPTIC trial. 45 milligram used to be the label. Here, a randomization was done between 45, 30, and 15 milligrams per day. And the goal of the trial was to optimize the ponatinib dose using the or achieving the optimal response, intolerance, or tolerance level. So what is the result? The goal of third-line treatment is the achievement of 1% BCR-ABL. This was tested here at 12 months, and the 20% level was the aim, was the goal of the study. That means the lower confidence interval limit should have been above 20%. And this was the case only for the 45 milligram. That means 45 milligram per day should be the starting dose if the patient does not have cardiovascular problems. In this study, the treatment was reduced to 30 and 15 milligrams, as the aim was to reduce to 15 milligrams per day to reduce the long-term side effects. And on the right side, you may appreciate that with the reduction from 45 to 15 and 30 to 15, in more than 70%, the response level was maintained. That means that's a good option to reduce the overall cardiovascular toxicity. And here, over the course of the disease, 6 months, 12 months, 24 months, you realize the advantage of the 45 milligram starting dose, even after reduction of the 45 milligrams to a lower dose. This is the case for both the high level starting BCR-ABL level and also the lower level. The patients who have less than 10% BCR-ABL have, of course, an overall better response likelihood than patients who have more than 10%. But in particular, for patients who have this high BCR-ABL load, the 45 milligram starting dose is a big advantage over 30 and 15 milligram. And this is the case also for the 315 mutated patient. Ponatinib is active against 315 here in blue, but you clearly see the advantage of the higher dose here over 30 and 50 milligrams for this specific mutation. Since this was a stepwise approach, the overall survival is identical for all the three cohorts, is just the efficacy, PCR response, and the tolerability, which is different. This is here tolerability. Of course, you see more cardiovascular side effects, arterial occlusive events in the 45 milligram cohort, but much less than in previous studies where 45 milligram was given continuously over the course of the disease. And this is depicted here in this graph. You see the differences in the response in blue and the differences in the cardiovascular risk profile in orange. And the difference between the 15 and 45 milligram cohort in terms of efficacy is 26%. In terms of tolerability, 6.4%. This gives a clear answer towards this approach to start with 45 milligrams, and when a level of 1% was achieved, to reduce the dose to 15 milligrams per day. Second story is Asciminib. Asciminib is a specific inhibitor which has a different mode of action as all the other drugs, the ATP binding site competitors. Asciminib binds to the myristoyl pocket here, and this cartoon shows the physiological situation. This myristoylated N-terminal end binds to the myristoyl pocket to inhibit, to auto-inhibit the ABL protein when ABL is not needed for the metabolism in the cell. But when BCR is bound to ABL, the myristoyl tail is not available anymore to bind to the myristoyl pocket. Therefore, there was the idea to imitate this binding of the myristoyl tail to the myristoyl pocket. And this is possible with a small molecule called Asciminib. On the right side, you see the inhibition of the BCR-ABL protein by this myristoyl pocket. Because, of course, there is the idea again to bind to the two binding sites to give a combination treatment. This was the initial idea, to combine an ATP competitor with this myristoyl binding molecule. It's a long story, over 8 years, but the end of the story is that for most patients, the monotherapy with Asciminib may produce a good response, but much less side effects than with the combination treatment. This here is the molecule. You see, it looks different as the ATP competitors because it binds, of course, to a completely different site. It's specific for BCR-ABL. These are cell line experiments here in blue, BCR-ABL negative cell lines, in red, BCR-ABL positive cell lines, and you see the clear distinction of the activity of Asciminib. All the other kinase inhibitors have an overlap between BCR-ABL negative and BCR-ABL positive cell lines. This is the largest phase 1 study I'm aware of in my professional career. It was a long study with a lot of different cohorts, but was a very comprehensive study as well. That means everything which is possible was tested. CML was tested, ALL was tested, combination treatments, monotherapy treatments, different dosages in all the situation, different mutations, 315 mutation, and other mutations were tested in this study. That means after we received the results of this study, we have a clear view on what is possible, what is manageable for the patient, and what is needed for the patients. The efficacy in the phase 1 study is shown here. Patients without 315 mutations, with all the different doses which were given in late-line therapy, 54% achieved a complete cytogenetic remission. And also for patients with 315 mutations, all the different dosages here, overall, 41% of patients achieved complete cytogenetic remission. We had the observation that a higher dose of Asciminib, actually 200 milligrams BID, produced much better responses in the 315 cohort. Therefore, this was separated from all the other developments, and 315 will receive a separate label with a higher dose, which was already done with the FDA, but will be done in other countries as well at a later stage. Combination therapies were tested as depicted here with imatinib, nilotinib, and dasatinib at a very early stage. This was, of course, tricky because we wanted to be sure that the efficacy of the ATP competitor is maintained, and therefore the dose of Asciminib was adjusted to the standard dose of the ATP competitor. It may be an advantage in the future to use the standard dose of Asciminib and adjust the dose of the ATP competitor for safety reasons. But this was not done here in this study at this early stage. But you see the response levels between 40 and 50% of patients achieved BCR-ABL level less than 1% in 48 weeks period. Asciminib can also be used after ponatinib in the situation of 315 mutations. Here in this cartoon, only the 200 milligram BID dose was considered. 57.8% of patients achieved by week 24, that means very early, a major molecular response, whereas in the ponatinib naive cohort. In the ponatinib pre-treated cohort, 28.6% achieved this response. That means it's worth to try asciminib even after ponatinib, in this case, in particular in patients with cardiovascular side effects or cardiovascular comorbidities. The registration study was done in the third-line situation or later-line situation, and here asciminib 40 milligram twice daily was randomly compared to bosutinib 500 milligrams once daily as one of the standard third-line therapies at the time the study was designed. The primary endpoint was an early endpoint, MMR at week 24. You see the clear difference between asciminib and bosutinib, knowing that these patients in the third-line situation need to achieve a very rapid response. Otherwise, in this late-line situation, we need alternative drugs or allogeneic stem cell transplantation. The key secondary endpoint was MMR at week 96, and the difference between bosutinib and asciminib is even larger after 96 weeks. Most of the bosutinib patients discontinued this therapy at this situation based on intolerance or based on lack of response. Therefore, the chance to achieve a new response was lower in the bosutinib cohort than in the asciminib cohort. This is the cumulative response curve between the two drugs. You see over the period of 96 weeks, there is still always an advantage of asciminib over bosutinib. The 1% level is by definition, by recommendation of the ELN, European Leukemia Net, the major goal of the therapy in the third-line situation. Therefore, this was analyzed as well. And you see over the course of the disease an overall advantage for asciminib, which is even bigger than for the 0.1% in all these time points. The event-free survival shows an advantage again. Here, it's important to know that an event was not defined as stopping based on intolerance and stopping based on or resistance. It's also the non-achievement of the ELN criteria for the third-line therapy here. Therefore, after 6 months of therapy, a lot of bosutinib patients had not achieved the 1% BCR-ABL level and therefore were considered as an event here. Deep molecular response is not our major aim in late-line therapy because we do not recommend treatment-free remission after 1 or 2 resistances, but this may be the case at a later stage. Therefore, it's of course of interest to know how deep molecular response levels are achieved. And you see here MR4 and MR4.5 and the asciminib in green and bosutinib in blue, a clear advantage for asciminib for all these deep molecular responses over time. What about side effects? The overall side effects are the dark blue and dark green columns, and the more than grade 3 and 4 and 5 side effects in light blue and light green. You see that there is a clear advantage of asciminib over bosutinib when it comes to the gastrointestinal side effects. But of course, we need to consider that the 500 milligram bosutinib was used here, which is still the label, but is not in the general use. We would start with 400 milligram in most of the patients currently. However, we see slightly more cytopenias, thrombocytopenia and neutropenia with asciminib compared to bosutinib. Why is this the case? What's the explanation? Asciminib does not act on normal hematopoiesis. This is quite clear from preclinical data. It does not inhibit KIT. Therefore, it's a question why we see these neutropenias. My explanation is that in late-line therapy, normal hematopoiesis is significantly reduced. And if a drug is efficacious, that means reduces the leukemic clone very fast, you may see a transient phase of thrombocytopenia or neutropenia or even anemia until the recovery of the normal hematopoiesis. And since the efficacy is advantageous for asciminib over bosutinib, this explains the transient side effects. And it's of course transient, it's certainly transient. We see this here on the in the right cohort. That means the first ever recurring and ongoing AEs are clearly dominant in the first 6 months of therapy, and they disappear over the further course of the disease. Therefore, I think in a certain frame, of course, we could and we should tolerate cytopenias when we treat a patient with asciminib. The overall quality of life shows a clear advantage for asciminib over bosutinib with all these different parameters here. I don't want to go into the details, but you see in blue an improvement of quality of life for all these parameters with asciminib, which is not the case for bosutinib. And also these interference items show an advantage for asciminib: mood, ability to work, enjoyment of life over bosutinib. Where does it go? We need more data for the full registration of asciminib. We need to know whether the twice daily dose is really needed or a once daily dose is sufficient. Therefore, we performed, Novartis performs together with the community this randomized study between 40 milligram BID and 80 milligram QD for late line therapy, starting with third line. And the goal of the therapy is primary endpoint MMR at 84 weeks. This study is called Ask for Opt, Optimize Therapy, and is currently ongoing. What else do we have? We have a new drug, a very exciting drug from a company called Enliven, active against BCR-ABL and also the 315 mutation, highly selective to ABL and BCR-ABL. That means the likelihood of side effects is lower, but we need to demonstrate this, of course. From the pharmacology, from the chemical profile, it does not inhibit the usual kinases, most importantly VEGF receptor, and therefore we have the hypothesis that this drug may produce less cardiovascular side effects, if any, compared to ponatinib, for instance. Animal studies were done showing the efficacy also for the 315 mutation, and the phase 1 study is currently ongoing. We were lucky here in Jena to enroll the first patient worldwide 2 weeks ago with the 10 milligram cohort. I have seen the patient today after 2 weeks of therapy. He is fine, the blood is fine. That means we will hope the best for the good response of this patient. It's a patient with who was on ponatinib without remarkable response, with cardiovascular comorbidities. Therefore, I think to reduce the cardiovascular risk is very important here in this patient. We have other drugs in Russia. Colleagues produced the PF-114, a phase 1 study was done. The major side effects is a psoriasis-like skin adverse event in the higher doses, but efficacy was quite good in the different parameters shown here. We have olverembatinib, very difficult to pronounce. The phase 1 and 2 trials were done in China. reported at the last ASH meeting, also active against the 315 mutation. Interesting adverse event is a skin hyperpigmentation in 86% of the patients, but efficacy was quite good. Therefore, the phase 2 study is currently ongoing. And we have vodobatinib, another drug in a global study, not active against 315, but also more specific towards BCR-ABL. Therefore, expectation is also the reduction of the cardiovascular side effects. I'd like to conclude that with all the different drugs available, we have a very good chance to optimize the response, but also the tolerability of the tyrosine kinase inhibitor therapy. We may transplant less patients, therefore, but we need to keep a very close eye on the specific situation of each patient. If he has biological negative parameters like isochromosome 17, for instance, which is, I think, the most nasty chromosomal aberration, we should consider allogeneic stem cell transplantation. But I think most importantly, currently with the long-term therapy of CML is to improve the quality of life for patients who need an ongoing therapy. Of course, we want to enlarge the cohort of patients who are eligible for treatment-free remission, but this is not our major aim in the third-line situation. Here, the quality of life, I think, is most important. Thank you very much for your attention. I'm happy to answer questions which may come via the chat. Thank you very much.
Thank you, Andreas. Thank you for a really comprehensive overview of where we sit at the later stages of the treatment of CML. And I guess, thank you also to Connie, who's brought to our attention, that the patient who's just died, it is still, with all these therapies, it is still important, obviously, to realize that there are patients out there who need continuing care, and still the work needs to be done to find the right treatment for the right patient. So thank you both. Again, we are welcome to take any questions, as Andreas said. If you'd like to raise your hand or to use the chat function, that would be great. I have had a couple of questions come in. And I can see Tim has asked a question. So Andreas, when do you start with ponatinib at a lower dose than 45 milligrams per day?
Yeah, I start with a lower dose in patients who have a cardiovascular comorbidity. I used to start with this lower dose because now, of course, I would prefer Asciminib in this situation if a patient has cardiovascular toxicity, if available, of course. Asciminib is currently in Europe not available for the 315 mutations in none of the studies. Therefore, for 315 mutations, we need ponatinib. And therefore, Tim is very right with this question. We need to consider a dose of 15 milligrams for patients who have pre-existing cardiovascular comorbidity. And we need to optimize, of course, the lipid levels in these patients with statins or other drugs. That means to optimize the risk, the vascular risk for these patients. There are a lot of Novartis people here in the chat. I can repeat what I said recently. We need a study for the 315 mutated patients. Very important, because we don't have the label, the registration in Europe, but we have these patients.
Absolutely. Question from Professor Cortez. What is your opinion on the optimal dose of Asciminib? Do you know what that is yet?
Fortunately enough, the very high dose, like 200 milligrams twice daily, which we are using for the 315 mutated patients, is very well tolerated. Therefore, we have a large window of opportunity. And since we know that the 80 milligram per day is very efficacious, it's a good dose to start with. That's very clear from ASCEMBL and also from the phase 1 study. That means we don't need the higher dose for most of our patients. However, we may have patients with alternative mutations which have not been elaborated in detail so far, which may need a higher dose of Asciminib, and therefore to be able to increase the dose over the course of the disease in case of non-response is of course an advantage. And we can go between 80 milligrams per day up to 200 twice daily. Of course, this depends on the reimbursement. We need to be sure that the insurance company pays for it. And this is not clear in all cases because the label in Europe will be for 80 milligrams per day.
Okay, thank you. So another question, so your preference, so which cases are you particularly looking to use ponatinib over Asciminib in the third line setting?
For the time being, of course, we were dependent on the definitions in the studies, in ASCEMBL and also in the Ask for OP study. Here, not all patients were eligible, but I think we will learn a lot from the cytogenetic analyses and from the genomic analyses here. And we will select a multi-kinase inhibitor versus a BCR-ABL specific inhibitor. I have only a gut feeling currently, and I do it according to the gut feeling. We need more data to clearly define in which case a multi-kinase inhibitor has an advantage over a specific drug. But we see in the ASCEMBL trial that only half of the patients achieved the response. That means the other half is intermediate or non-responder. That's third line situation. The conclusion was BCR-ABL is still the driving force in most of our patients, but not in all. And this needs to be discovered in the next, I hope, in very early in the next year or so.
Okay, I guess sort of following on from that, do you have a feeling sort of were there particular patients that you're still looking to move to allogeneic stem cell transplantation rather than sort of to ponatinib or Asciminib?
Yeah, I've seen a patient today who is in his early 30s, had two mutations, 253 and 315. The 253 was eliminated by ponatinib, but the 315 is still there on a low level, 1% BCR-ABL currently, but 100% of this 1% BCR-ABL is the 315 mutation. So this patient was until last year, 2 years ago, a clear candidate for allogeneic stem cell transplantation. Young patient, the sister is identical, HLA identical, but he was reluctant, and I understand that. We have now Asciminib. He is theoretically eligible for Asciminib, but as I mentioned, 315 is not in label and will not be in label in Europe. And therefore, if a patient is willing to go for experimental therapies, then he is a candidate for the new drug, which I mentioned. But he is, of course, currently on ponatinib. He has no cardiovascular comorbidity. Therefore, we could continue ponatinib. He is, since still 100% 315 mutated, he is still on 30 milligram, not 15. But he's very well and is very well informed about the developments which will come. And on this information, he decided to avoid allogeneic stem cell transplantation for the time being. I think this illustrates in which a situation we are and what we discuss with the patient. We have experimental therapies. We don't know the outcome of experimental therapies, of course, but on the other hand, we have, as a salvage treatment, allogeneic transplantation available. This is, of course, in contrast what I said at the beginning, that we need to transplant early enough, but that's actually a shared decision between the doctor and the patient.
Thank you. Okay, so probably just time for one more question that's come in on the chat, and it's sort of, again, sort of really probably about personal practice. So the question is, so if a standard dose is too high, how do you review it and modify it in the label, and how long would this take?
For which drug? For Asciminib or?
So bosutinib at 500 milligram is too much.
I don't start with 500 milligram. This was done in the ASCEMBL trial, but I don't do it. I start in most patients with 400 with some prophylaxis, of course, against diarrhea in the background, and this works in most patients. Yeah, I don't start with 500 anymore. This is, of course, acceptable for the reimbursement because it's cheaper than the 500. Okay. And for the other drugs, I don't use 400 nilotinib twice daily anymore. I use 300 twice daily in all cases, also after imatinib resistance. And dasatinib is, I think, the best example. We have lots of studies and lots of reports available from MD Anderson, for instance, demonstrating that 50 milligram per day is for the standard patient sufficient to achieve the response. But we have, of course, other patients who need more. And my personal opinion about dasatinib is that a 5-day schedule per week has an advantage over 7 days. This is only possible with dasatinib, not with the other drugs, because of the short half-life and the lack of any trough level of dasatinib, which may produce, if it's too low, may produce resistance. We have a study ongoing, which is almost finished, which will, the last patient, last visit will be in February next year. And then we have the results whether this option, 5 days versus 7 days, is a reasonable option as well.
Great. Okay. Thank you. And thank you, Andreas, for giving us sort of this really great overview of the current situation in this third line setting after 2 TKIs. It's quite fantastic to sort of be hearing about, you know, Asciminib, which is so new, but still looking at new drugs coming on. So still a great deal of news, excitement to be considering.